When it comes to cataract surgery, I think the most important thing you're gaining with a femtosecond laser is predictability. Of course, most of us can do capsulorhexis, and most of our capsulorhexis are great, but are all of them great? I have to say, no. Nobody can really say you have a capsulorhexis size of 5.2 millimeters in 100% of the cases, and this is what you gain when you move on to the femtosecond surgery in cataract. And what is important about the technology, let me say a couple of sentences before I come to my talk, is the movability and the versatility. Whenever you get a new technology, you do not need to construct a new operation theater to offer it to the patient, so you just can offer it to the patient using the same versatile system. And using such a versatile systems, we still need to talk about the safety, and this is what my talk is about. I report on intraoperative complications of laser-assisted cataract surgery in a real-world setting. So the purpose was to report the rate of intraoperative complications. This is a retrospective study using a low-energy femtosecond laser. And what does it mean, high-volume real-world setting? It means that it's not coming from a prospective setting. It comes from real-world. It's a private hospital. We're doing more than 6,000 cases in a year, and both surgeons who have done the femto laser surgeries are doing more than 1,000 cases a year. So it's a high-volume real-world setting. We consecutively looked at our case series, and we looked at our surgeries done between 2015 and 2019, and they were done in either hands of 2 experienced surgeons. And we excluded the first 20 cases of the surgery because we know there is a learning curve, and I will be happy to report even on the complications in the first 20 cases. But as we started the study, we said, okay, we need to exclude the first 20 cases because of the learning curve. And we reviewed our surgery reports. So what was the surgical technique? We used the Zimmer Z8. We did the lens fragmentation with 80% laser energy in an 8-piece pie pattern. We did a capsulotomy of 5.2 millimeters with 100% laser energy. We adjusted the capsulotomy size and the position according to intraoperative OCT images. Afterwards, we moved to the phacoemulsification. We did the incisions manually, 1 main incision, 2 paracentesis, and we used the Alcon Centurion system for phacoemulsification, bimanual IA and IOL implantation. What was the study cohort? 1,806 eyes of 1,000 patients. The youngest was 21 and the oldest lady was 99. So we're looking for the first 100-year-old patient to be operated on. And it was half right and left eyes. The surgery was done in peribulbar anesthesia and sedation, except in cases who were on systemic anticoagulation with warfarin, fenprocomol, and or similar. So what are the results? We just have 5 single cases of capsular tears, which is equivalent to a rate of 0.28% with a confidence interval of 0.04 to 0.52%. We had 3 cases of anterior capsular tears, and the surgery could be moved on with regular IOL implantation in the back. This is equivalent to 0.17%. We had 2 cases of posterior capsular tears, one with anterior vitrectomy, and in both cases the surgery could be completed with IOL implantation in the sulcus. This is equivalent to a rate of 0.111. We had no cases of vacuum loss, and we had no other intraoperative complications to report. Let's look at those 5 complication cases. 3 of them had hard nuclei, means LOX3 of 4 or more. 2 showed with positive posterior pressure, and all of them had some challenging conditions like floppy iris, shallow anterior chamber, posterior subcapsular cataract, and primary capsular fibrosis. So the question arises, so having 0.2 of complications. Is it high or is it low? So we looked into the literature and we tried to differentiate between, to distinguish between the high energy and low energy reports. And if you see in the high energy, we have complication rates around 1%, going up, if you're looking at the publication of Popovic, of up to 5% capsular complications. So if you see, if you're starting as a surgeon doing cataract surgery and you're expecting 5% capsular complications, I think every surgery would be challenging. And looking down to our series, if you're going down to 2.8%, it makes you feel more comfortable. And of course, first, we do not harm. Well, we need to take care that we do not, we are not only looking at different technologies, we are looking also at different surgeons. But when it comes to anterior capsular tears, I think the most of the cases are related to the technology. And again, if you look in the high energy data available, we have between 1 and 1.77%, and looking at the low energy data, the safety goes down to 0 and 0.17. So it's around 5 to 10 times less likely you experience the anterior capsular tear, and it gives you a bit more of safety. So to take home message, this is, to our knowledge, the first large study reporting on intraoperative complications. Why is nobody has reported it before us? Because they are so rare. And if it's rare, so the most surgeons, they do not see the necessity to report on it, but I do see the necessity because safety also counts. There were no complications except for a low number of capsular tears, and I believe so that the low energy concept seems to allow a stable capsulotomy. This is my conviction. Anterior and posterior capsular tears, in any case, did not result in a disadvantage for the patients. IOL could be implanted successfully in our cases. We do not have comparative data to conventional phaco emulsification, but we do have historical data to high energy devices, and I think the comparison, although it is not a head-to-head prospective study, is quite clear. You reduce the possibility of experiencing tears by factor 5 to 10. And of course, when you have so low numbers of complications, you need even larger study cohorts to have better data and better reliable data. Thank you for your kind attention.